Good evening and welcome everyone to our very first emergency medicine virtual tour at London Health Sciences Centre. My name is Allison McCluskey and I am the Senior Development Officer here at London Health Sciences Foundation. Together with my colleagues and the emergency medicine team joining us here tonight, we want to thank you so much for your interest and your passion to learn more about the incredible work happening here in our emergency departments at Victoria Hospital and University Hospital. We have an exciting tour lined up for you this evening, and we hope you enjoy this exclusive behind the scenes donor experience. In tonight's virtual tour, you'll get a sense of what it takes to meet a range of critical needs at any moment. As one of the largest acute care hospitals in southwestern Ontario, LHSC's emergency medicine department sees over 185,000 emergency visits a year. Our panelists tonight from our emergency medicine team will be Dr. Christy McDonald, Dr. Frank Meislich, Dr. Brad Rostis, Dr. Mary Fotheringham, Dr. Jake Pace, Dr. Samir Mal, and Dr. John Dreyer. So before we get started, I'd like to let you know a few things about the tour. Everyone right now is currently muted to protect the sound during our presentations. This session is being recorded. Today's tour will be divided into 5 sessions. So throughout the sessions, if you have any questions at all, please feel free to write them in the Q&A chat button at the bottom of your screen, and we will do our very best to answer all of your questions at the end of our tour. So thank you again, all of you, for joining us, and we hope you're inspired by tonight's presentations. To start off today's session, I'm pleased to introduce you to Dr. Christy McDonald, Citywide Chair Chief of Emergency Medicine. Dr. Christy McDonald started with LHSC as a physiotherapist before completing medical school at the University of Toronto. She returned to London and Western University for residency. She's been on staff at LHSC since 2008. She has been interim chair chief since June 2019 and is thrilled to now be permanent chair chief since July 2021. In addition to her role, Christy is the co-chair of the COVID Operations Executive for LHSC and continues to work to keep us all safe. Dr. McDonald will be presenting an overview of the emergency medicine department and will be broadcasting live from her office at University Hospital's emergency department. Welcome, Dr. McDonald.
Great, thanks very much, Allison, and welcome everyone. We are absolutely thrilled to be sharing our emergency medicine program with you tonight. I'll just begin by sharing my screen and we'll go ahead and get started. So again, Shannon, I assume I'm okay, am I? Here we go. I think I'm okay now. So thank you again, Allison. Thank you to all of you for joining us here tonight. Tonight is an exciting evening for the emergency medicine program. We are thrilled to bring you on a virtual tour of our citywide emergency department. This evening, you will see us from the resuscitation room at University Hospital. Over the next couple of minutes, I will take you through a very brief history of emergency medicine, give you an overview of emergency medicine in London, share our team complement, touch very briefly on COVID-19, and then introduce you to our educational endeavors. Emergency medicine is a relatively new specialty. In 1968, the American College of Emergency Physicians recognized that emergency medicine and those practicing it required a unique skill set and required a unique body of knowledge to care for patients requiring emergency care. The first board certification was in 1975, with the first formal examinations occurring through the American boards in 1980. In the early 1980s, Canada followed suit, and the Royal College of Physicians and Surgeons of Canada and the Canadian College of Family Physicians of Canada recognized emergency medicine as a distinct discipline, with first exam being completed in 1983. The specialty continues to grow and adapt to the needs of our patients and to adapt and incorporate ever-improving technology. Our emergency medicine program is a citywide program. We provide clinical care to our community of London and surrounding area. Our LHSC sites are University Hospital, Victoria Hospital, and the Children's Hospital. Our physician group also provides care at St. Joseph's Healthcare Urgent Care Center. Our academic training includes Schulich School of Medicine and Dentistry and the Arthur Labatt Family School of Nursing at Western University, as well as a number of other academic partners, including Fanshawe, Lawson, and others. We have a very large emergency medicine team, both full and part-time, that includes about 250 nurses, about 60 communication clerks, 40 emergency department technicians, social work, physical therapy, occupational therapy, environmental service workers, and approximately 90 emergency physicians. We truly are a team and function as a team to provide the best care to our patients. As you are likely hearing in the media, our emergency volumes continue to climb. We see approximately 6,000 patients per month at Victoria Hospital and about 5,000 per month at University Hospital, in addition to our pediatric emergency department visits and our St. Joe's urgent care visits. Over the past year, you will see in this graph, the volumes continue to rise. But one thing that we can't appreciate from this graph is the complexity and the acuity of our patients. And that also has increased dramatically. As a community and as healthcare workers, we've been greatly impacted by COVID-19. As we face more uncertainty with the most recent development of Omicron, we continue to be grateful to our community. Many of you will remember these pictures from our local media. The convoys and support from the community continues to grow and continues to give us more strength. The rock gardens that you see in the center of the screen continue to bring a smile as we walk into and out of work each day. As an emergency medicine team, we check in with each other and support each other and enjoy being a family at work. Our academic growth continues on a steep trajectory. Over the past 24 months, we have developed programs that reinvest in our growth in emergency medicine. We have created an educational bursary fund to support our emergency medicine assistant and associate professors, that's our rank from the university, to support ongoing education. This year, for the first time ever, we've set aside dedicated academic funds to develop our pillars of excellence within emergency medicine. We have a dedicated body of knowledge in emergency medicine, and we need to continue to strive for excellence and be on the proverbial cutting edge. Over the next number of minutes, I look forward to sharing our pillars of excellence with you. You will be introduced, as Allison has, to Dr. Frank Meislich and Dr. Brad Rostis, our experts in point of care ultrasound, to Dr. Samir Mal and Dr. Jake Pace, our experts in airway, to Dr. Mary Fotheringham, our expert in simulation, and to Dr. John Dreyer, our leader in research. We look forward to continuing to grow our pillars and truly make emergency medicine in London a national center of excellence. Thank you for joining us here tonight. I hope you will enjoy the tour as much as I will. I look forward to joining you again at the end for our Q&A. And Allison, back to you.
Thank you so much, Dr. McDonald. Thank you so much for that overview of emergency medicine. And with that, up next, we have Dr. Frank Meislich and Dr. Brad Rostis. So I'll start with a bio on Dr. Meislich. Dr. Meislich is a full-time emergency medicine physician and the director of POCUS, Point of Care Ultrasound at LHSC. He graduated from the ER program here in London and then completed a fellowship in point of care ultrasound at the University of Ottawa. Originally growing up on a farm in Chatham, Kent, he wanted to return close to home and saw the potential for LHSC to be a leader in ultrasound. From there, he helped to create one of the first accredited POCUS fellowships in Canada, which attracts trainees from across the world. He's the current director of the Emergency Medicine Ultrasound Program and is a leader in teaching learners of all levels. His special interests include resuscitation, health informatics, palliative care, and quality improvement. And joining Dr. Meislich, we have Dr. Rostis, who is a recent graduate of emergency medicine program at Western University. During his 4th year of residency, he completed the point of care ultrasound fellowship and became one of the first fellows to successfully pass the National Board of Echocardiography examination in critical care. In addition to his position as a staff physician in emergency medicine, Dr. Rostis has also taken on a role as the undergraduate point of care ultrasound curriculum lead with the Schulich School of Medicine and Dentistry. Doctors Meislich and Rostis will be presenting point of care at LHSC, broadcasting live from the emergency department resuscitation bay at University Hospital. Welcome.
Awesome. Thanks a lot, Alice. Welcome to Resus 3 at University Hospital. So I'm going to be giving a little talk. Actually, Doctors Mel and Pace will be here afterwards giving the airway. And we got Dr. Freeman, one of our trainees and previous POCUS fellow, and then Dr. Rostis. So I'm going to give a little talk on point of care ultrasound, and give me one sec as I boot up the PowerPoint here. All right, so I'm going to kind of make a case for excellence here. No intro needed, but what is POCUS? I think it's a great question that we have to first ask ourselves. So it's also known as point of care ultrasound, bedside ultrasound, or focused ultrasound. So basically it's when a provider actually does ultrasonography at the bedside of a patient, and it actually answers specific clinical questions. So more or less, rather than going to a radiologist, a technician performing the scan, getting an interpretation, coming back, really what we traditionally think about ultrasound being. This is actually senior physician at the side doing this kind of focused assessment, answering a very specific question. And it's kind of what's called a disruptive technology. So just to kind of use an analogy, a lot of big companies over time have had disruptive technologies. If we look at Blockbuster going to Netflix, the post office going to email, and Uber kind of surpassing taxis in some ways, all of these have had a disruptive technology that's kind of shaken the paradigm. And POCUS has done very similar to us in emergency medicine. When we think of imaging traditionally, so if someone comes in with belly pain and you're worried about appendicitis, you want an ultrasound to look at that appendix. Well, I don't know if anybody knew this, but at University Hospital, for the most part, we have ultrasound available between 8 a.m. and 6 p.m. And at Victoria Hospital, it's between 8 and 11, where on weekends, it's kind of limited between 8 to 4, 8 to 5. So in those kind of late evenings at university, or even on weekends or, in the middle of the night at Victoria, we don't have that access. So we actually have to bring people back the next day. And there's a lot of only set availability and spots available. So, if we think of other things like CT scans, time can vary, right? There's only a certain bandwidth that we have, and there's a lot of acute problems, anything from strokes to traumas. And those can certainly kind of shift where our priorities are in the department of needing urgent scans. So it can be anywhere from a couple hours to even 6 to 8 hours till we get it set, read and done. So it all depends on the indication and volume, but ultimately there's only a set amount of imaging we can do in our department. So that's kind of where POCUS came in. If we think of an ultrasound machine back in the 60s, going back in that historical time, they've gotten smaller and smaller as time has evolved, to the point where we've got our little bedside machines you'll see in the bottom left corner, followed by like a little handheld devices that go to iPads and even to our iPhones at this point. So machines have certainly kind of shrunken over time. We really like miniaturization in ultrasound, and specifically Emerge. We go, when we think of cell phones getting smaller and smaller over time, or what I always like to think about is Zoolander. But we really like those small kind of devices, and I think that's what POCUS best represents. What you see here is the ME8. So this is actually one of our flagship ones that we use for POCUS, and we're going to show you that very shortly in a live demo here. And it actually has the availability in the bay to hook up to our screens and be able to show kind of for everyone to see what we're seeing in terms of the patient, which could be for resuscitative purposes or diagnostic or otherwise, which is great. Specifically for POCUS in London, we have internationally recognized fellowships where we have trainees from across the globe coming here. We also have elective opportunities where we draw people all across Canada and North America from other universities. We really do actually excel in this field. It's something we're really proud of, actually. When we think of things that we use for Emerge, we actually kind of do the spectrum. We teach medical students, residents, consultants, but we actually do things with paramedics, nursing, branching out into things like respiratory therapy and otherwise. So there's a big sort of use across the board with regards to other places and types of trainees that we teach. We do a lot of good published articles. I was going to put a whole bunch of articles up here, but I just didn't. Rather, you can look online and you can look for all the published articles there, but we do publish a bunch across different specialties. We do a lot of international multi-center research trials, which I know will be talked about in the research portion. And we are currently looking at other projects looking at nurses and respiratory therapy uses too. And we actually do form some partnerships with AI and health informatics, talking to robots in the hospital. So there's a lot of stuff, not only from patient care, but we kind of do across the hospital. just as a current landscape that we do here at Victoria, we actually have 7 machines total, but 4 of them are greater than 9 years old. We got 2 in the last 3 years at the start of the pandemic. And then the one that we're about to show you that was actually bought with donation funds. At university, we're a little bit worse off. We've only got 5 machines here. One's 13 years old, same with 2 being greater than 9, and same 2 that within the last 3 years. So I'm going to get the cost in a second, but let's first start with Dr. Rostis here. So he's going to give a little demo, and we're going to go over point of care. I apologize for the shaky cam that's about to come with this, but hopefully it should work okay. Let's see here.
Hello. Yeah. So I'm Dr. Rostis. It's nice to meet you all. I'm going to be talking about the ultrasound machines. This one here, which Dr. Meislich mentioned, is the M8. This is one of our donated machines, and probably the best one that we have here. Very quickly, I'll just show you the probes that we use. So there's typically in any ultrasound machine, there's 3 probes. This is called a linear probe. This one here is our cardiac probe, and then this one is our which I cannot get out, is our abdominal probe. And essentially, each probe has its own specific purpose when we look at different areas of the body to answer different questions. One thing I'll show you really quickly is as you can see, those along the side here are the 3 different types of probes that I just mentioned, and you can switch between each probe and choose the type of exam you want. So if I select the cardiac probe, you can see the different cardiac options. You can also use it for other purposes, lung, brain. If I switch to this other type of probe, there's other exams we can do. So we could do a testicular exam for somebody coming in with acute testicular pain, because sometimes that can be an emergency. You could do vasculature. So we could look at arteries and veins if we wanted to insert IVs, or do central lines, which are IVs that go into really big veins in the neck. What's actually interesting is, and it can sound kind of funny, but the ability to quickly switch between probes is actually very important. If you think about a resuscitation where you need to look in somebody's belly to see if there's evidence of bleeding, and then very soon after look at their heart to see if there's blood around their heart, which could be an emergency. Being able to switch between probes is really important. In some of our older machines, they've served us very well for a long period of time, but actually what happens is when you switch between different probes, the machine will sometimes completely turn off and have to reboot. And so you can imagine in a situation where there's 7 physicians and nurses and EDTs all around a patient, and it's a critical situation, trying to get answers quickly and your machine shuts off, that's can be a little bit of a problem. So I thought what we do is just show you how we acquire some images. And since the heart is a very interesting thing, and most people know that it beats, we thought we would show you kind of what we do in this situation to look at somebody's heart. So we throw some goop on our probe. We select that we're going to be doing a heart study, and hopefully you can see the images on the screen here. So with Dr. Freeman lying down here, what I do is I take the probe and I put it on the patient's chest, and you can see that within seconds I can start to see an image here, and I'll try to optimize this a little bit. So this is Dr. Freeman's heart, and you can see here I can start to see some important things. So this is his left ventricle and his left atria. These are the chambers where the blood flows through the heart. And what I can actually see is this is the border of the heart, and I can tell right now that there's no fluid around the heart where there shouldn't be. I can see that the heart's beating really well. I can move my probe around and so if I twist it, I can get different kind of views, and here we see a different sort of orientation of the heart, and it's a circle that's squeezing together. I'm just gonna see if I can zoom in on that there. And so I can start to get a sense of how well this heart is functioning, and it can answer really important questions very quickly. I thought, Frank, if you want me to look at the abdomen?
Yeah.
Sure. So if we take another probe, it's the abdominal probe. This would be an example of looking at some structures within the abdomen. So I'll switch my probe here. I'll pick the abdomen. And as you always warn the patient, cold goop. It's always a little bit uncomfortable when you throw that on there. So what we can see here, so I'll show you a couple structures. And Shane, can I get you to take a big breath in and hold it? So this structure here, I know sometimes it's hard to even fathom that we can kind of even tell what's going on here, but this bright white thing right here surrounded by the dark, that's his kidney. And if we look up here, we can see his spleen above it. In a trauma situation, This view is really important because we're looking for evidence of bleeding in his belly, and we would see it right here. So right now I can say the belly looks good, at least in this particular spot. One other thing I'll quickly show you, see if we can show his aorta. If somebody were to come in with abdominal pain, one of the things that can happen is your aorta, which is the big blood vessel, can get too big and actually start to leak, and that can be quite dangerous. And so what we can do quickly here, for example, if you see this little black circle, that's his blood vessel that carries blood from his heart all the way to the lower half of his body. And I can quickly scan the entire, Frank, if you just want to show the probe here, if I just run this probe all the way down his stomach, I can follow that blood vessel from the start to the finish and make sure that everything looks okay. And it really gives us a very quick answer as to what might be some of the causes of this patient's belly pain. So that's just a couple examples.
All right, back to me. When you're looking at those machines for a standard POCUS, if we bought it kind of off the street, if you will, between everything, it costs somewhere between $140,000 to $150,000 for the machine, depending on the probe type, and every probe costs something different. Here at LHSC, for that kind of ME8 that we spoke of and other types of what's called minery machines, the partnerships actually gives us a really good deal. And so the average cost is somewhere between 70 to 80. So quite a significant reduction. Ultimately, when we're looking at is replacing that fleet, if not increasing the access more. So there's access basically in every other spot in the emergency department. It's not only used by us, but it's used by trauma, by surgery, by medicine. So it's really big. We looked at a couple of those cases just to kind of, show you some pathology real quick. When we talk about that AAA that Dr. Rostis alluded to, there's that aorta right in the middle there. And then there is something that we can catch within minutes, right? So you can see how big and significant that is. Rather than wait hours for imaging, this patient ends up going right to the OR with vascular surgery, essentially saving their life. More importantly, probably where we found a really big significant one is someone who's pregnant and bleeding. Certainly in the middle of the night, waiting till the next day is not always the most optimal. So if you can look to the left here, you can see what is a pregnancy. And on the right side, obviously we can see like a little flicker of a heart rate with inside there too. Again, kind of showing that importance of reassurance in the moment for someone that's pregnant. And just to kind of follow up on that, we can also show when there's a pregnancy outside the uterus too, something that's more of a life-threatening emergency and getting the gynecologist involved. Overall, we can see if there's fluid and kind of initializing tests rather than waiting until morning. And when we talked about things, we have something called the TE probe. That's something, there's Dr. Freeman with his mask on and shirt on. And what we can see here is what's called a Transesophageal View. So basically looking at the heart down the esophagus and behind, and we can use this for resuscitative cases. So overall, that's quite a big thing, being able to look at it in real time and just seeing that kind of function of the heart comparatively. So POCUS in medicine, we use it for all kinds of stuff: symptoms, procedures, resuscitative and diagnostic, and therapeutic has a big value to us too. So I'm going to stop there. I know I've taken a significant amount of time, but I'm certainly available for questions at the end. And thanks a lot for letting us speak about our program.
Wow, amazing. Thank you so much. Thank you, Dr. Meislich. Thank you, Dr. Rostis. That was incredible. And thank you to all of our donors who have supported POCUS. And that was just a wonderful presentation. Up next, I'm pleased to introduce you to Dr. Mary Fotheringham. Dr. Fotheringham completed her medical degree at Dalhousie University in 2009 and residency in emergency medicine at the University of Toronto in 2014. Since 2015, she's practiced emergency medicine here at LHSC. She's an assistant professor and clinician teacher at Western University and is the director of simulation for the Division of Emergency Medicine. Her passions include medical simulation, pre-hospital event medicine, and Star Trek. Dr. Fotheringham will be showing us a simulation demonstration and will be broadcasting live from her home. Welcome, Dr. Fotheringham.
Thank you, Allison, and thank you everyone for joining us today. I am very grateful for the opportunity to speak to you today about my passion, which is simulation, to tell you why it's so important to me, to my patients, and why I think and hope it should be important to you as well. Simulation in medicine is a way of bridging the gap between classroom learning and real life experience. You can imagine how important it is for doctors to have experience with certain procedures or with helping critically ill patients without having only read about them in books. The same way airline pilots spend thousands of hours in a flight simulator before flying passengers, or the way professional sports teams would spend hours running plays before a game. Doctors spend hours resuscitating patients in simulation rather than learning on real patients. In medicine, we use simulation to practice vital skills, tasks that can save patients' lives. These might be procedures that we don't see very often but are potentially life-saving, or tasks that are routine but require great skill. Every medical student has practiced putting stitches in to close a wound on a banana or on a piece of pork belly from the grocery store before they actually suture a patient's face. That's an example of what we call low fidelity simulation, or simulation that mimics a real life situation, but not closely. We also use what we call high fidelity simulation with a higher degree of realism. These sessions focus on more than just a single task and more closely mimic a real life situation, but in a safe environment where no harm can come to a patient. These are more stressful for participants than the low fidelity sim, but give everyone the opportunity to run through a situation, then reflect and discuss how it went in a post-simulation debriefing, which I'll show you later. Our emergency medicine simulations take place either in the simulation theater, which can be a classroom or a sim center, or in situ, meaning in the environment in which we work, such as our resuscitation bays in the emergency department. We use mannequins that are often able to have their vital signs, like their heart rate, their breathing, changed remotely. They have pulses like a real patient. Some are even able to talk and make noises. We use makeup to show injuries, sometimes even add simulated blood or vomit with actual smells to make it as realistic for the team as possible. Realism is the key to getting patients to engage in the exercise, or participants to engage in the exercise, to take it as seriously as they would with a real patient without the risk to patient safety. These simulations are vital to team building and to providing high quality patient care. There is a need within our department to acquire new simulation mannequins, rhythm generators, and airway equipment that is congruent with what the hospital equipment uses in order to continue to provide the best simulation experience for our teams. Our emergency department team not only uses simulation to train our own residents, but we use it to train medical students and residents from other specialties that are on their emergency medicine rotation. What this means is that almost every physician in training at LHSC will do simulation through our emergency department simulation program at some point. We also use simulation to keep up the skills of our entire emergency department team, including staff physicians, nurses, respiratory therapists, technicians, and communication clerks. Interestingly, the vast majority of medical errors are not a result of lack of medical knowledge on the part of the team. There are actually 80% of errors come from gaps in communication skills and teamwork. Simulation is the only place that these critical teamwork and communication skills, or what we call crisis resource management skills, can be practiced and perfected so that teams run smoothly during life-threatening situations. Even if the members of the team are not the same every day, when all emergency healthcare providers have learned these critical teamwork skills by doing simulation, they can come together and work like a well-oiled machine when sick patients come into the department and the stakes are high. In addition to helping learn technical skills and improving teamwork, high-fidelity simulation in the emergency departments have been used many times to identify gaps in our systems, to anticipate barriers to patient care, and to respond to changes in our protocols. For example, the way we resuscitated a critically ill patient changed dramatically when COVID hit. We had to change the rooms we used. Fewer people were allowed in patient rooms to perform important tasks. We had to adapt to using physically cumbersome personal protective equipment, including masks and shields, and that made it hard to communicate with your team members. We had to change some of the equipment that we use for procedures involving airway secretions to protect ourselves and other patients in the department. All of these were tested and improved with practice by using simulation. Before the new rooms were used for actual patient care, we ran drills in the new environment to learn how to best serve our patients and protect our staff. Without simulation, we would have had to learn and identify issues as we treated real patients, which increases the potential for making errors along the way. Our in-situ simulations have identified gaps in our systems that we have addressed in advance and likely have saved lives. It is within our vision that within the next 5 to 10 years, we can achieve a simulation center that would bring together airway, resuscitation, crisis resource management, and point-of-care ultrasound to continue to develop our teams. I'd like to show you a short video of some simulations that were filmed specifically for you to highlight our emergency medicine simulation program. These are edited to show the main points, as these simulations typically run about 15 minutes with about a 30-minute period for debriefing. You'll hear my voice explaining what is happening as the video plays. Allison, can you go ahead to the video, please?
I have a group of residents ready to participate in a simulation. I have advised them that they are working in the emergency department and that the ambulance will be bringing in a 21-year-old male soldier who was injured during explosives training on the base. He was hit with an explosive and thrown down some stairs. At this point, they will have an opportunity to ask questions and prepare themselves and their team for the arrival of the ambulance. Here you can see them putting on personal protective equipment as the patient or mannequin arrives.
Airway Manveer, you're talking up on a monitor.
Hi there, sir.
IV access.
My name is Dr. Barnfield. He's speaking at all to me? He is not. He's not. I'm just looking for foreign bodies in the airway. I don't see any foreign bodies in the airway. It's trachea midline.
The doctor listening to the lungs has identified that the patient has a collapsed lung on the right side and communicated that to the team leader. You can see in the upper right corner what these residents see on the monitor. Here you can see the instructor adjusting the patient's vital signs remotely, including heart rate and blood pressure, which should change the management of a patient as he becomes more critically ill.
60 gauge right AC.
And Manveer, can you grab the ultrasound and just have a approach the slide?
Do I see any obvious injuries to his abdomen? No. Belly soft.
They have simulated the use of ultrasound to confirm that the lung is collapsed. Off screen, they were shown a video clip of what this would look like in a real patient.
And then Manveer, you get a chest tube.
Sometimes a learner will miss a task and the patient will become acutely more ill. Or if they identify and manage that task, the patient will stabilize. Here you can see the control panel to change vital signs in real time.
Line for the fifth intercostal patient, if I want to do it.
You just saw one of the physicians describe as he performed a procedure to manage the collapsed lung.
Chest tube's in on the right.
So we'll hook the chest tube up to suction.
And here you can see the team immobilizing the neck in case there is a spinal cord injury.
So I'll stay for the head.
And now we see the team immobilizing the pelvis in case there is an injury causing internal bleeding.
Rebecca, can you start CPR?
And here you can see that the patient has lost his pulse and become critically ill, and the team are reacting appropriately. They are communicating their plan to resuscitate him and put him on a ventilator.
So to start off with Kaleidoscope, we could have backup. We have a gauge machine here, and we do have some LMAs at the bedside.
Fentanyl.
And Rob, you're
Right AC 16 gauge bilateral.
Okay, so I'll use this one, and then afterwards, would you like me to get a central access?
through
Once they're
subclavian.
intubated, yeah.
I think that's probably a good idea
Okay.
if we have time for that prior to general surgery, taking this gentleman to the OR. So any concerns there? Otherwise, we may move forward to proceed with intubation.
As long as someone can help me with midline stabilization.
Yeah, we have not yet heard from general surgery, so let's page them again.
They're tied up.
Rebecca's gonna put a subclavian line in.
Yeah, I'm gonna do a.
Sometimes there are mechanical tasks or procedures that we discuss right away. So here you will see us go through and demonstrate how to properly place the pelvic binder and discussing how to protect the neck during intubation.
Are you ready with your
Can you hold the just up there for me, please? Or right there. So I'm going to suggest you put your hands more here. Make sure that you're keeping the tube open.
So the intubation, we have our tube right there.
During CPR, it is extremely important to have good quality chest compressions. We can use the mannequin to show the person doing the chest compressions on the heart how hard they need to press to be effective. We have this technology for real patients as well, but practicing and being physically aware of the amount of pressure it takes on a mannequin improves their ability to get good results in real patients. And now we come to arguably the most important part of the simulation, which is the debrief. This is an opportunity for all participants to reflect on what happened, how they felt, what they understood to be happening, and discuss with the others if there were issues with communication or things that they could improve upon. They get feedback from the instructor, but most of this is facilitation of a discussion of everyone's understanding of the situation and how things could have gone more smoothly.
A young gentleman that was involved in a blast injury with subsequent injection fall down, multiple stairs and about 20 feet. He had a right-sided pneumothorax, a positive fast, and fluctuating level of consciousness, requiring initially a right-sided chest tube. Subsequently, he arrested and we put in a left-sided chest tube. Found his pelvis, activated a massive transfusion protocol, activated trauma team, as well as general surgery. He stabilized post resuscitation with the massive transfusion protocol. And essentially, the plan for him would be to OR once general surgery had arrived.
There was some good closed loop communication. You summarized the case, I believe that.
I think it was great stuff as a leader. You were able to flatten the hierarchy, and that we were able to feed back our ideas and anything that we noticed that may not have been something that crossed your mind. So I think we all felt really safe, and it was a good learning environment for them right away.
Excellent job, team. Here is an example of an in-situ simulation, which means a simulation run in the actual resuscitation area of the emergency department, rather than in our sim room or a classroom. These show real staff members who are wearing exactly what they would for a real patient, using real equipment, and in the actual room where they would treat the patient. The only difference is that this is a mannequin. By running simulations in the true environment, we can see how to improve things like placement of supplies, or to make sure that things would run as efficiently as possible if a real patient were being treated. We inform other services like the intensive care unit, the ECG and X-ray departments, the blood bank, the telephone operators, anyone who might be involved, that this is an exercise, but to respond as they would in a real situation. This way, we can identify gaps in our processes that might affect patient care. During this exercise, we learned that the paging system was not alerting the blood bank of the dire need for blood, which caused a delay in getting blood to the patient. Identifying this issue during a simulation allowed the hospital to rectify this error. Had this happened during a real-life event, it's possible that it could have cost the patient their life. This shows how important these simulations are to the hospital, staff, and patients. These are some other photos of our faculty doing simulation training in the emergency department, as well as practicing their airway skills in the simulation room. This way they can get comfortable using the newest tools we have with a mannequin, rather than having to learn or troubleshoot during an actual emergency with a real patient.
In summary, simulation is a vital part of today's medical education and quality improvement in our hospitals. It makes for skilled doctors and efficient teams. It helps hospitals become safer for patients, and inevitably, it improves the quality of patient care and saves lives, which is what all of us in healthcare and in the community want. Thank you very much for your time. I'll turn things back over to you, Allison.
Thank you so much. Wow. Thank you so much, Dr. Fotheringham, for preparing that simulation and for sharing that with us. So thank you. Just a reminder for all of our guests watching tonight, if you do have any questions, please enter them into the chat and we will be answering those at the end. And up next, I'm pleased to introduce you to Dr. Jake Pace and Dr. Samir Mal. Dr. Pace is an emergency room physician at LHSC. His clinical practice includes emergency medicine, as well as functioning as a trauma team leader and trauma inpatient physician. His research interests include emergency airway management, trauma triaging tools, and the resuscitative care of traumatically brain-injured patients. Dr. Mal is consultant physician in emergency medicine and trauma team leader at LHSC, and also a transport medicine physician with Orange. He completed medical school at McMaster University in 2008 and his emergency medicine residency at Western University in 2013. After completion of his emergency medicine training, he traveled to work as a pre-hospital doctor with the New South Wales Ambulance Service, Sydney in Australia. After this, he also completed a secondment as a pre-hospital doctor with London's Air Ambulance in the United Kingdom. Since returning home to Canada, it's been his passion to use the local and international pre-hospital training he's received to help shape the delivery of pre-hospital critical care to the patients of Ontario. Doctors Pace and Mal will be presenting on emergency airway management, broadcasting live from the resuscitation room at UH. Welcome.
Thank you very much, Allison. We appreciate everyone's time, and thank you for letting us present here at this great event. As Allison said, my name is Dr. Mall. I'm one of the emergency physicians and trauma team leaders here at Ellen Health Sciences Center. Beside me is Dr. Pace, who is also an emergency physician and trauma team leader. Today, we have the pleasure of talking to you about airway management in the emergency department and what a crucial skill that is for us to have to be able to serve the patients that present to our emergency department. It's a very complex topic, and to help understand it a little bit better, I'll hand it over to Dr. Pace to talk about a case.
Yes, we wanted to frame airway management in terms of a case to give you a mental model in terms of the think about what we're talking about. So unfortunately, for the last 22 months, we've all been affected by a worldwide pandemic, and COVID pneumonia has been a complicated and scary presentation for patients to present to the emergency room with. And I want you to picture a male in his 50s who's presenting with COVID pneumonia. He's struggling to breathe, his oxygen levels are low, and unfortunately his body is shutting down and failing. He requires mechanical ventilation, and we've heard a lot about mechanical ventilation in the news. But the process of taking someone who's awake and breathing on their own and placing them on a mechanical ventilator can be complicated. And this process is what encapsulates emergency airway management. In order to be placed on a mechanical ventilator, we need to place something called an endotracheal tube, which is this long piece of plastic in the patient's mouth, throat, and into their lungs. This is quite an uncomfortable process. If you think about the last time you drank water and it went down the wrong tube, that's the protective nature of your lungs that's preventing things from entering the lungs in a wrong fashion. And that type of pain and uncomfort would be experienced by patients if we don't provide adequate medications to help place that breathing tube to put them on the ventilator. In order to do this safely, we have to administer very powerful medications that both reduce a patient's consciousness, but also take away their ability to breathe with a paralytic agent. This is an extremely high-risk time period in the emergency room, and it's a skill set that emergency physicians must maintain in order to treat their patients safely. If we cannot get the breathing tube in the right place, and then subsequently cannot help the patient breathe, this could become very quickly a life-threatening circumstance, and it's a set of circumstances we must be proficient in to adequately treat people in resuscitative scenarios.
Airway management happens every day in the operating room as well. And comparing the case that Jake talked about to what happens in the operating room often when patients are going in for elective procedures, the very skilled anesthetists that we have the benefit of meeting those patients at least a few times before the operation, coming up with a safe plan for anesthesia, making sure their patients are adequately prepared with having empty stomachs and good blood pressures and good heart rates prior to the day of the surgery. Unfortunately, in the environment that we practice in, we don't have that same ability with our patients. We need to be open at all hours of the day to treat all sorts of emergencies. And in this uncontrolled setting, we need to adapt our procedure and have a safe system around us such that we can proceed with emergency airway management in a safe place. As done poorly in this environment, the risk of dying from this procedure is about 1 in 25. So this is extremely dangerous. Airway management is the first step in any effective resuscitation. It's what allows us to take control of someone's body, of someone's heart, their blood pressure, their breathing, and then to safely allow this patient to carry on in their trajectory of care throughout the hospital. If you think of some of the cases in which airway management is required, the list is quite long, but Jake mentioned severe COVID and other infections, head injuries and other major traumas, cardiac events like big heart attacks, strokes, overdoses, and the list does go on and on. This is a procedure that we are attempting to develop a safe system around within our emergency department so that we can deliver it at any hour of the day with any members of our team and do it safely.
So now that we can all appreciate the importance and high-risk nature of this procedure, I think most people would feel that it's intuitive, that we would be tracking how we perform, looking at our complication rates in the emergency room. And unfortunately, we didn't have that until a couple of years ago when the division realized there was a deficiency in our self-evaluation and our ability to learn from cases and also improve to prevent errors from occurring again in the future. The recognition of this deficiency led to the establishment of an Airway Registry, where we essentially track data from every patient who's intubated in our emergency rooms. And we use this data from a multi-directional approach. The first way we use is just observing and tracking what our rates of success and failure are in the emergency room. And then we use those numbers to try to come up with strategies to improve patient care. And we do this through a bunch of different ways. We have sort of bi-monthly rounds where we meet as a group to discuss challenging cases and see if anyone has different approaches to cases that are inherently difficult for all members of the team. We look at developing unique educational opportunities for both physicians, nurses, and RTs to again approach challenging cases from a different perspective and ensure that we're all working from the same mental model when we're dealing with these sick patients. We're using this data to publish research to improve national standards in terms of airway management. And finally, to develop targeted hands-on educational opportunities using the simulation mannequins that Dr. Fotheringham was previously describing.
Hand it over here. So that's a bit of the theory behind emergency airway management, but I think it'd be worthwhile showing you some of the equipment that we have available to us when someone with an airway emergency presents to the emergency department. So if we start off on Jake's left hand, actually, we'll go to the most basic. So when people are having a difficult time breathing and their oxygen levels may not be as high as we would like them to be, this is the most basic way that we can help assist someone who's got a good respiratory effort, still able to expand their lungs appropriately and breathe out. This is what's called a non-rebreather, where we can just apply some oxygen at a very high flow to turn what is 21% oxygen into close to 100% oxygen for our patient. However, oftentimes in the case that we discuss, like severe traumas and bad infections, this face mask in and of itself is not enough. And that's where we progress down some of our airway emergency algorithms. If we need to provide a little bit more support, this device here is called a bag valve mask ventilator. So here what we do is we, using two hands, we tightly seal a mask on a patient's face. And then this helps create a higher pressure, kind of like sticking your head out of a window. And this allows the lungs to expand and us to get even more oxygen under pressure to a patient's lungs. The next step after this, if patients are still failing and require even more oxygen and help breathing, is we progress to what Jake was referring to with endotracheal intubation. And the blade itself doesn't look like anything too fancy or special, and we'll show you the technique here. But everything that goes around putting this blade into the patient's mouth is what makes this procedure so complicated. We have to give powerful medications to help put someone to sleep, to help paralyze their muscles so that the patient can tolerate having a sharp metal blade put in their mouth. And when Dr. Pace is actually looking with the direct laryngoscope, this is the most basic of intubating devices. And Dr. Rostis, if we can just have you over on the screen here. He's trying to find the vocal cords, which are those structures way in the distance. And if you can think about a patient who's had maybe some facial trauma and it has lots of blood in the mouth, or maybe they just had their dinner a couple hours earlier, their mouth may be full of other stomach contents, it can be extremely difficult to find this small little hole while a patient's paralyzed and their oxygen levels are dropping. Airway management over the course of the last 20 years has progressed to even more tech. And next up here is we have something called a video laryngoscope, which allows the team around the individual performing airway management to become involved. Using this video laryngoscope, which has a camera on the tip of the device, we can then insert the blade into the mouth in a very similar technique. And now looking over at the screen, the entire team in the room can visualize what Dr. Pace is doing and help share a mental model to troubleshoot any difficulties that he may be having. And again, those are the vocal cords there leading into the trachea, which we're trying to stick a plastic tube into. Over the course of the last few years, there's become even more recognition of there are difficult patients in which putting them fully to sleep or potentially even paralyzing them completely may not be the best idea because their anatomy is such that we may not be able to pass the tube afterwards. Right here is a device called a flexible intubating scope, which our department purchased a few years ago, which for anyone who's fished an electrical wire, I'm not one of those. I just practice medicine, not handy skills, but this is a flexible intubating scope that allows Dr. Pace to fish a preloaded endotracheal tube through the mouth or the nose, go around, navigate corners, and then find the vocal cords and subsequently find the trachea to place a plastic tube within to help this patient go on a ventilator. So that's Dr. Pace going into the trachea. So with a combination of all the devices that we've shown you here, the very basic direct laryngoscope, our oxygen masks, our video devices, and our flexible scopes, we have a full armamentarium of equipment in which we can safely place any patient who is in respiratory distress, having trouble breathing, on a ventilator in our emergency departments for whatever the cause.
Our vision moving forward is trying to establish a program that allows us to train both our physicians, trainees, nurses, and RTs with all the different techniques that are available to us for challenging cases in the emergency room. We want everyone to have a similar skill set and have a standardized approach to airway management. I think our end goal is a program called a clinical cadaver program, in which bodies of the deceased are prepared in a fashion that maintains a very realistic and lifelike preservation. This technology is already developed and already present in Canadian centers, most notably Halifax at Dalhousie University. And it really increases the fidelity of manipulating the airway, which is a very challenging scenario to recreate with a mannequin model. Our needs are multifactorial, which include equipment purchasing, very basic equipment purchasing, such as how we store our airway equipment in an ergonomically mindful way that allows physicians who are in a setting of a crisis to work through their algorithms quickly in an organized fashion, to purchasing advanced video laryngoscopes that have different techniques and different benefits, and then finally establishing a clinical cadaver program.
As Dr. Fotheringham spoke about earlier, it's really important to give physicians, much like our peers in aviation, as much time in their real environment as possible so that we can practice these high-risk procedures in the setting in which we work. These mannequins have been great in order to help train our trainees and our consultant physicians using some of this equipment. But the final step in the gold mine, so to speak, would be a clinical cadaver program, which Dr. Pace and I are hoping to develop within the next 5 to 7 years at the University of Western Ontario and really be one of the leading centers in the country. That's all we have to say about airway management. So we'd like to once again say thank you to everyone who is listening, and we appreciate the invitation to come here and speak with you. Thank you.
Wow, amazing. Thank you so much. Thank you, Dr. Pace. Thank you, Dr. Mal, for this behind the scenes look at airway management and, sharing your expertise and sharing your vision moving forward. So thank you both. Up next, we have our final presenter. Just a reminder, if you do have questions, please feel free to enter them. We'll try to get to as many questions as possible. If we do not have a chance, by all means, we will be happy to follow up individually with you. So for our last presentation, I'm pleased to present and introduce you to Dr. John Dreyer, a graduate of McGill University and the Johns Hopkins Emergency Medicine Residency. Dr. Dreyer has been a member of the Faculty of Medicine since 1984. He was Chief of Emergency Medicine at Victoria Hospital and LHSC from 1988 to 2001. During his time, London went through major restructuring of its hospitals. Dr. Dreyer was responsible for the concentration of all emergency care at the 2 sites of LHSC and for continued operation of an urgent care center at St. Joseph's. He led the redesign of both the emergency departments at Victoria Hospital and University Hospital in the early 2000s. Currently, Dr. Dreyer is Director of Research. He's been awarded honorary life membership in both the Ontario Medical Association and the Canadian Association of Emergency Medicine. Dr. Dreyer will be presenting an overview of the emergency department's research program, broadcasting from his home. Welcome, Dr. Dreyer.
Thanks very much, Allison, for your kind introduction. And thank you, everybody, for coming to join us this evening. I must say, I'm very proud of the program that I'm affiliated with. And I can say that the program has come a long, long way since I joined the department in 1984. It's almost like going from the horse and buggy era to the space age. And that's how much emergency medicine has progressed. And you know, you're seeing some real leadership in the individuals who are presenting to you tonight. So yes, it's my pleasure to talk about our research program, and some of the individuals that you already heard from tonight play an active role in that program. But I'd like to give you kind of a general overview of the types of research that we do, and where we think we're headed in the future, and really what the goals are for our research program. So I thought I'd start by just showing you some of the faces behind the program. Let's start first at the top of the screen. Next to me is Dr. Justin Yan. He's a clinician researcher who's been with us for, I think, about 6 years now. He came through our residency program, and then he did a fellowship in Ottawa with one of our national we're very proud of a national and international researcher, Dr. Ian Steele, and Justin worked with him, and then came back to London, where he's a clinician working about 2/3 time in the department, and then I'd say another 50% of his time. So I think he works a lot more than a 1.0 FTE. And his area of specific interest is diabetic emergencies, specifically patients who have very high blood sugars. Their diabetes is completely out of control. Next to him is Dr. Naveen Punai. He's a very accomplished pediatric emergency physician with an amazing track record in research. He's the holder of multiple national grants from the Canadian Institute of Health Research. And his area of, so I would say, sort of most major interest is the control of pain in pediatric patients in the emergency department. Frank Meislich, you've already met this evening, and Frank is our POCUS expert and leader of that team. And he's involved in some interesting research that I'll speak to a little bit later, but specifically some lung ultrasound in COVID positive patients, and transesophageal echocardiograms, which were demonstrated for you earlier. Dr. Lisa Shepard is one of our senior staff members. She's a full professor at Western, and her area of expertise is in what we call qualitative research, which is sort of the soft side of research, in that it's less about sort of numbers and particular characteristics of patients and what we did to them and how they've survived and or not. It's more about the quality of their experience, both on the patient side and on the provider side. So it's largely conducted by small group interviews or individual interviews with either patients or care providers to see how they felt about the experience and how we can ultimately improve that experience. Dr. Matt Davis is the head of what we call pre-hospital care. So he's the director of the Southwest Ontario Base Hospital Program. So he gives direction to the paramedics and what they do in the field. And he does research in this area as well. So hoping to optimize the care of patients before they get to the emergency department. And that can make a huge difference in terms of how patients do in the ED and what their outcomes are going to be. Dr. Carrick Lubani, some of you may be familiar with his other claim to infamy when he was on a trip to the Middle East and was unfortunately arrested in Egypt and spent a month or two in prison there before he was released. But that really, the reason for him being there was all about his passion, which is trying to improve medical care in developing countries. And specifically what Dr. Lubani has already done is he's developed a low-cost stethoscope that can be produced using a 3D printer. And so all you need in order to produce a stethoscope is the 3D printer and the rolls of plastic that feed into the printer. And so for a few dollars, it's under, I think it's about $5, he can produce these low-cost stethoscopes when the average stethoscope in North America and the developed world would be minimum of $150 and oftentimes a few $100s for a good quality stethoscope. So this is a big advance. When he went to, when he realized that this was a problem, he was actually visiting Gaza and he discovered that they only had one stethoscope amongst, to use on several different floors. So if somebody wanted to listen to somebody's heart or to their lungs, they would actually have to go and find the one and only stethoscope on those several floors. And so with the introduction of his new very low cost stethoscopes, they can now actually make them in Gaza, and every medical student and every clinician there can have a stethoscope. So he's actually changed the paradigm of care in that part of the world. And his next two projects are actually development of a low cost electrocardiogram and a low cost open access saturation monitor. And those are pieces of equipment that normally cost between 10 and 20,000 per unit. And he will likely be able to produce them for a fraction of that. The four people across the bottom are essential members of our research team, our two research coordinators, Christine Van Arsen and Branka Wojcik. And they're the ones who sort of make sure that our research projects move forward and make it to fruition. We get gentle reminders from them as to what we need to do as clinician researchers to make our project successful. And the two people on the right at the bottom, Tom Chen and Firdausa Helani, are our research assistants who, without them, we wouldn't have the data that we need from the projects that we've undertaken. So altogether, and there are others in the department, obviously, who do research, but these are sort of, this is a sort of a look at the core group. So besides the types of research that I've already mentioned, and I've already actually alluded a little bit to COVID-19, and I'll come back to that in a minute. Point of care ultrasound, Frank has talked about, and all of those techniques that he showed us, those are things that one can do, as it were. They're not experiments, but one can report on how care may have improved as a result of using ultrasound. For instance, simulation, again, you can measure the abilities of your trainees and of your existing staff and determine whether or not their skills are better. When you put them through a sim course and then you examine them 3 months or 6 months or a year later to see if the skills have actually stuck. And you can also look at patient outcomes to see if those who have been exposed to simulation are actually providing better care than those who have not. So that's important work. Medical education is again something that we tried to do research on in terms of how we deliver a program and whether or not we're getting the outcome in terms of the learning that we want. Clinical decision rules are important in emergency medicine in particular, but also in other branches of medicine. But what we do here is we try to determine what the predictors are of a certain disease or injury being present. So the classic one is an ankle injury rule, where if you meet certain criteria, then you need an X-ray, and if you don't have those criteria, you don't need an X-ray. So that can be used even by nurses, and is to this day, to determine whether or not the patient should be fast-tracked directly to X-ray rather than waiting to see the doctor and then waiting another half an hour or an hour to get the X-ray. So it can actually speed up care quite dramatically and avoid unnecessary X-rays. And those clinical decision rules can be developed for all sorts of problems in medicine and help make us better physicians. Quality improvement and quality assurance is something that's ongoing all the time, trying to make sure that we're delivering the best possible care that we can. So in terms of the types of research studies that we do, sort of going from well, I probably shouldn't say from the top to the bottom, but we think of the prospective studies, which involve including clinical trials, are thought of as being the best kind of research. Although there's a place for less precise, I might say, research as well. But clinical trials would be things like giving a patient a new drug and then randomly assigning patients to either getting a new drug or not getting that drug, which you can only do ethically if you're sure we don't know whether or not it's actually going to benefit the patient or not, but you can't do it if you suspect that there may be significant harm. So there are those sorts of studies that we get involved in. There are also prospective observational studies that we do in terms of just gathering data on a particular subset of patients. So for instance, Dr. Yan's diabetes database, where collect data on all patients who come in with high blood sugars. And then he can determine by looking at the demographics and the reason for the presentation, what might predict them coming back on a later date in a worse condition. So ultimately that can lead to better care as well. Retrospective studies we do a lot of, where we're doing charts of patients who we've looked after, and we survey physicians and patients alike to find out what their experience was like. And again, looking for things that we can improve in their care. So that's really all part of quality improvement and quality assurance. And then at the same time that we're doing our own projects, we often collaborate with researchers at other institutions with their studies. And that's an important thing to do, because ultimately we will need them to help work on our studies. And so it's a sort of a, you scratch my back, I'll scratch yours kind of thing. So I'm just going to talk about three particular studies that are ongoing at the moment that I think are quite exciting. This one is Dr. Yan's study, and we just started a couple of months ago. It's a randomized control trial. It's taking place only at Victoria Hospital at the present time because it's a pilot. And we're going to try to determine which of two different salt solutions is better for the resuscitation of patients with diabetes that's out of control. And diabetic ketoacidosis, those of you who are diabetic probably know all about that. But for those who aren't, it's when the patient doesn't have enough insulin to get sugar into their cells throughout their body, and they get into a state where the blood becomes quite acidic, and then all the organs their function starts to deteriorate, and ultimately, if the right resuscitation is not undertaken, patients can die from this. So the primary outcome he's looking for is the time to resolution of this state called diabetic ketoacidosis. And he's comparing these two saline solutions to determine which is actually better. And there's some evidence from other research projects that suggests that one might be better than the other, but it's not definitive. So the results are going to provide high-level evidence to change current practice and may affect the management of diabetic ketoacidosis around the world. The second one is also one that Dr. Yan is involved in, and it's open study, which is a play on opioids unused medication, or opiate unused medication, OPUM. It's a collaboration with the Université de Montréal and several other emergency departments across the country. It was launched just a few weeks ago at both of our emergency departments at LHSC. And the objective here is to determine the quantity of opioids consumed during the acute pain phase. So 2 weeks after a patient is seen in the ED and discharged with acute pain, usually with a prescription of some sort of analgesic. Ultimate goal is to decrease opioid misuse by decreasing the amount of unused medications following discharge. So it's a tricky balance. You want to give the patient enough medication so they're not in horrible pain, but we don't want to give them too much such that there's leftover, and sometimes the leftover meds are stolen and then get into the circulation in the community. Other times, somebody takes them inadvertently and may end up with an overdose. So this is really research at the forefront of addressing the current public health emergency relating to opioid use. So a very important project. And then finally, to talk a little bit about the COVID-19 research that I alluded to before, we are currently participating alongside 45 other emergency departments across the country in this registry. The registry collects data on patients who present to the ED with COVID-19 and everything that we do for them, the tests that they have, what causes them to have to be admitted to the intensive care unit, how they do in the intensive care unit, and so on. So it's by collecting all this data, it ultimately will lead to better care of those patients. Something that I think Dr. Mal and Dr. Pace referred to in their presentation as well. At the international level, Dr. Meislich is also involved in this study involving COVID patients, looking at lung ultrasound for both the diagnosis and prognostication for those patients. And that's a study that's being led by Australian investigators. So other current prospective studies, I talked about Dr. Yan's hyperglycemia or high blood glucose database, looking at the patient characteristics and so on. We're involved in a study of patients with irregular heart rates, atrial fibrillation, looking at predictors for when they need to be admitted and when they can safely be discharged. Again, a very important issue for us because we simply don't have beds to admit everybody to hospital. And so it's trying to decide who really needs it and who doesn't. So having a guide or a framework with which to make those decisions is really important. So this is part of developing that kind of a guideline. Resuscitative Transesophageal Echo Registry. Again, we got a very brief look at what the heart looks like when you put a probe down the esophagus, and then you get an unobstructed view of the heart. And doing that during resuscitation gives us incredibly valuable information about the state of the heart, whether the patient needs more fluid or possibly blood, whether we need to give more medications to make the heart contract better. All of those things can be determined doing this transesophageal echocardiogram. And then the sprain trial, which is something very sort of simple and easy to do, but may be very helpful. This is a study going on largely in the pediatric emergency department, but people between the ages of, I think it's 12 and 18, looking at how they do, so their clinical outcomes, whether they are given just simply paper instructions or whether they're given an app to put on their smartphone, which will take them through the kind of things that they need in order to get back to full mobility. So what are the goals of our research program? I suspect that this is very similar to the goals of most medical research programs, but ultimately we want to improve the quality of care based on scientific evidence. We want to improve our educational methods in order to produce better clinicians. We want to develop new clinical tools and equipment to improve care. We want to promote the use of clinical decision rules for better care. and to collaborate with other centers of excellence to promote best care. I think our next great step forward is going to be to bring a full-time researcher into the department, likely in the form of a PhD researcher who will be able to help us write grants, to bring in money from both provincial and national, even international funding agencies to fund our ongoing research. We have had a moderate amount of success in this already. And as I mentioned, Dr. Punai has been quite successful with the Canadian Institute of Health Research. But I think that's going to be where what our major need is going forward. So at this point, Alison, I'd like to turn it back to you, and I think you take it forward from here.
Wonderful. Thank you so much, Dr. Dreyer, for that very informative overview of emergency medicine research. Thank you so much. Hi, Dr. McDonald. So we do have a few questions. We have one for Sim, we have one for POCUS. Let me just open up my chat here. So I see Dr. Meislich, Dr. Mel. So for POCUS, we do have a question. How many machines are needed for each emergency room? Can POCUS hook up to each screen easily? And how quickly can you set up each machine?
Well, thanks for the question. I think with regard to the machine, I mean, we talked about 7 being at Vic and then 5 being here. Ideally, we'd like 10 at each site, kind of within the last 5 years of being of its lifespan, because they're going to need to be refreshed. So I'd be looking at 10, and all kind of more recent machines would be the ideal scenario. To answer the question about the screen hooking up, I'm going to just pivot to the side here. We ran out a little time, but as you can see, here's the machine, and then this is hooked up to one of the screens and TV up there. So pretty straightforward. It's a straight up HDMI hookup that's very similar to your TV at home, essentially. So it requires some wires, but ultimately it's not really that complex. So we'd be looking at that being displayed for everybody. And sorry, Alison, you said there was a third question?
How quickly can you set up the machine, which I think you've addressed. And well, there was an additional, can it take pictures and video to share with other doctors?
Yeah, for sure. With regard to the saving of the video, all our images are archived here. So that's part of kind of the current and future, which is the ability to save all the images, be part of the patient medical record. And then we can actually, we're working on projects of sharing that with the radiologist in communication. And it's certainly available for other clinicians and staff. For example, if we have a really good trauma or a critical care case, usually those pictures are saved. And then we kind of liaise with our colleagues in the other specialties to look at it. And then how quickly it boots up. The newer machines can be seconds. Some of the older machines can be a few minutes, unfortunately, just like booting up an old computer. And just to show you kind of one of our older machines, this is that nice little 13-year-old tank, if you will. It works fine, but it can take a few minutes to kind of warm up and get to a capable state. So it serves its purpose. And then we have an older machine in the background there, that one, the Sonosite one. You can see some tape on the edge, on the handle. So it's a little bit more beat it up. It's currently turned off because the battery doesn't last long. Again, kind of like an old laptop that needs to be plugged in. And so you can see it trying to boot up right now. It'll probably be another minute or two before it's usable. So that's kind of our current lay of the land with these machines.
Great. Thank you so much, Dr. Meislich. We have another question for Airway. So Dr. Mal, Samir, this would be great if you could answer. How many times a year do you have to do the Airway procedure? Oh, and Dr. Pace too.
All right. No, it's a great question. Apologies, I didn't mention that. So it is extraordinarily common here at London Health Sciences Center. We perform approximately 1 airway emergency intubation per site per day. So between University site and Victoria site, we're performing approximately 650 to 700 intubations per year. And we're doing our best to track every single one so that we can make targeted interventions and targeted equipment purchases and find out where our deficiencies are and find out where our strengths are as well.
Excellent. Thank you so much. Dr. Fotheringham, we have a sim question. How many sim mannequins do you have, and what are the benefits of having different models?
That's an excellent question. For the emergency department simulation program, we have 1 mannequin and we have 1 intubatable head, which is just a head and lungs. The mannequin that we have works less than half of the time. It's just a very old model. It's almost 15 years old, so it's a little bit out of date. We usually rely on renting or borrowing equipment or going to other facilities to do our sim. Of course, for in-situ sim in our theater, we have to borrow equipment and have it brought in. There are different mannequins, different models with different purposes. They have mannequins for newborn babies, for children, for adults. They have ones that are specific for point of care ultrasound. They're very high tech for that. The sort of generic one that we use is one that can be intubated, can be defibrillated, and can do chest compressions. We do a lot of the makeup and or moulage for things like trauma, etc. And then of course they have ones that are specific for airway, which can have like the tongue can swell up or the vocal cords can freeze, because you can't intubate an easy mannequin all the time and then be able to practice your difficult airway skills easily in a patient. So, and then they have separate task trainers that are specifically for putting big veins, lines in the neck, veins, etc. Things like that.
Wow, excellent. Well, thank you so much. And I think that's it for our questions. If there were any, we will absolutely be following up with you individually. So thank you for those excellent questions, and thank you for the excellent answers. Dr. McDonald, I'll hand it back to you as we wrap up our virtual tour.
Great, thanks very much, Allison. And thank you to all of you donors. It's been an exciting evening for us in emergency medicine to prepare for presenting the excellent work that we do. I hope you found it informative, and we're certainly happy to answer any questions as they arise. And thank you very, very much for your time here this evening. Although we hope we don't see you in Emerge, we will be more than thrilled to care for you if the need arises. So back to you, Allison, and enjoy your evening, everyone, and happy holidays.
Thank you so much. Thank you, Dr. McDonald. And thank you to our entire emergency medicine team for, for your time, for all your effort preparing your presentations and these demos. It really was really exciting to see, behind the scenes glimpse into the world of emergency medicine. And to you, our donors, our supporters, our partners, thank you. Thank you for joining us tonight. We hope that you're inspired. We're grateful that you've taken the time to learn about the incredible work being done. As you can see from the simulation to POCUS, Airway, the research that's coming out, that's happening here in London is, making a direct impact on patients. So thank you so much. And that concludes our tour for tonight. So on behalf of our team, we wish you and your family a very happy and healthy holiday season. Thank you and good night.